Good afternoon, ladies and gentlemen. Today we are going to talk about avascular necrosis of femoral head, meaning that where we lose the vascularity of the femoral head, leading to a spontaneous onset of pain in young individuals, usually because of binge drinking, or after, as post-COVID we have seen, maybe because of steroid use. Traditionally, we have been doing core decompressions, fibular grafting, and in recent times, we had tried doing plasma, stem cell, and for the first time, the new technology which has come in, that we have been able to isolate osteoblasts, which are impregnated in the target lesion, that is a bone, after we do the decompression. My colleague and my dear friend, Dr. Rajat Chopra, is going to put some light on this.
Thank you, Dr. Sarabjit. Namaskar, everyone. I am Dr. Rajat Chopra. I am one of the senior consultants in orthopedics in Ganga Hospital. So I'll be giving you a little bit of insight on the management of avascular necrosis and what new can be done for this problem, which has been going on for a very long time. Avascular necrosis, as the term suggests, avascular, that means the blood supply is compromised, and necrosis is cell death. So the compromised blood supply leading to cell death. So what happens is that because there is no blood supply to the femoral head, the cells over there, the osteoblasts, the osteocytes, they are dying. So because of that, there is a space, there is going to be a subchondral collapse, and which will lead eventually to arthritis of the hip joint. It is affecting the younger population of our country, so that's why it's important, and the management is also, that's why, tricky. So if we look at the epidemiology of avascular necrosis, around 10,000 to 20,000 cases a year. But in our country, I think the incidence is more. And the common causes are steroid, which is being misused in our country a lot, and alcohol abuse. Trauma, yes, definitely, it will lead to avascular necrosis, post-traumatic arthritis. And we have seen recently a lot of cases because of steroid use as a lifesaver during COVID. And in terms of investigations, there is no good medical, you can say blood test, which can pick up avascular necrosis of the hip joint. So the x-rays in early stages are going to be normal, so we have to depend on MRI. MRI is going to pick it up early, and the classification of the disease and the treatment is also based on the MRI findings. Management challenges. So as I said, that this is going to affect the younger population more, and the treatment modalities that we have are not that great, except total hip replacement. So I'll just go through it. There is no medical management. There is no medicine or a drug that we can give and say that we can cure avascular necrosis. Unfortunately, we don't have it right now, but in near future, if we get it, that would be great. So in early diseases, in early condition, when the patient are able to pick it up, I think co-decompression helps. But if we find the case which has presented to us a little bit late, then total hip replacement is the treatment of choice. That's the gold standard. But limitation of co-decompression is that it is going to reduce the intraosseous pressure. So that helps in the pain relief in that patient, but it does not address the cellular deficit that has happened because of the necrosis, the cell death. And that's why it has got a high failure rate, and most of the patients after co-decompression end up replacement done. So why total hip replacement? And if it is a good choice, then why do we need more management modalities? It's a very good surgery. It works very well in avascular necrosis of the hip joint. Total hip replacement will give you a good 20-25 years that you can walk pain-free, do your routine day-to-day activities, but it is not the treatment of choice in a younger individual. As I say, because total hip replacement will give you, let's say, 20 to revise, the implant fails. So you have to revise, you have to put a new prosthesis in. So that may give you another 10-15 years. So if you are doing a total hip replacement in a 20-year-old, at stage 40, at the age of 40, you have to do another surgery. At stage 50, or maybe 55, you have to do another surgery. So by the time the patient is 60 or 65, they may end up in a wheelchair. So doing a total hip early is not a good option. so impaired stem cell differentiation. So this is the modality that we are using in our hospital now. It's known as ALCO, autologous adult live cultured osteoblast. So this, the ALCO is basically trying to replace what is missing. And it is a precise treatment, and we have a standardized dose of what we can inject into it. And it's the patient's own mesenchymal cells that are grown and into matured osteoblasts, and which are